Oh, good morning, everyone. My name is Denise Dador, and I'm the medical reporter at ABC 7. I've been there for 25 years, and this topic is very near and dear to my heart. And so it's great timing, perfect timing that we are joining up today for this virtual town hall. And we're going to be talking about the state of lung cancer. A new report came out today at the same time that we are doing this virtual town hall. So it is excellent timing. And thank you so much for joining us because we know this disease affects so many of you. We have wonderful experts with us who I'm going to introduce right now. Dr. Arya Amini, he's the associate professor and with the Department of Radiation Oncology at City of Hope, and Dr. Ravi Salgia. He is a medical oncologist, professor and chair, Department of Medical Oncology and Therapeutics Research at the Arthur and Rosalie Kaplan Chair in Medical Oncology and Therapeutics Research. And I mentioned who I am, and I am so happy to see all of you today and hope that we can join in community, get some answers, get information that can truly help our loved ones who are dealing with this, help ourselves, and get empowered. And that's why we're here today. Community Connections is a virtual town hall designed to educate and inform all of you. It's providing access to leaders. So we are talking to people at the very top and to our families and our loved ones and our patients. We're here today because November is Lung Cancer Awareness Month. And again, as I mentioned, the State of Lung Cancer 2023 report just released this morning from the American Lung Association. And this year's report shows us that life-saving lung cancer rates in California are far too low. That's our state, too low, just at 0.7% of those at high risk having been screened. We don't understand why the technology is out there and people aren't getting the message. But this is something that can be caught early, and we hope that you take this message to everyone you know. This year's report shows that life-saving, I mentioned that, and the 5-year survival rate across the nation has increased. So there's great news, 26.6%, and still often not caught until the 5-year survival rate, yes, increased, but it's often still not caught until late stages when it's less likely to be curable. People of color continue to face greater challenges and worse outcomes compared to white Americans, including lower survival rates, and are less likely to receive adequate treatment for the disease. We urge everyone to learn more about lung cancer because it is a #1 cancer killer. It has been always at the top of my reports in all the years that I've been doing this. And we want people to know if they're eligible or not to get life-saving cancer screenings. So if you go to lung.org/lung cancer, that is where you're going to learn about that. City of Hope's mission is to deliver the cures of tomorrow to the people who need them today. Founded in 1913, City of Hope has grown into one of the largest cancer research treatment organizations in the US and one of the leading research centers for diabetes and other life-threatening diseases, with an independent National Cancer Institute designated comprehensive cancer center at its core. And City of Hope brings a uniquely integrated model to patients spanning cancer care, research, and development, academics, and training and innovation initiatives. Joining us again, I want to give you a little more background on Dr. Arya Amini, Associate Professor of the Department of Radiation Oncology and Chief of Thoracic Radiotherapy at City of Hope, and Dr. Ravi Salgia, Medical Oncologist and Professor and Chair at the Department of Medical Oncology and Therapeutics Research. Doctors, thank you so much for being with us today on this wonderful day where we're giving lots of information to our community. To start off this conversation, can you both give us a little background on yourselves, a little more than I've given? So Dr. Amini, let's start with you.
Sure. Well, thank you for having me. I'm excited to be a part of this great session. My name is Arya Amini. I'm a radiation oncologist at City of Hope, focusing on thoracic malignancies, including lung cancer. I've been here 6 years. Prior to that, I was at my training at the University of Colorado and UC Irvine Medical School. So I was born and raised in Southern California. Excited to have the opportunity to be working at City of Hope, where we've led, honestly, the fight against lung cancer from the clinical side to the research side. And I had the pleasure of working with amazing colleagues, including Dr. Salgia here.
All right. Dr. Salgia, before I have you talk a little bit more about your background, I just want to let everyone know that if you have any questions for our experts, please type them into the Q&A section there on this Zoom. The Q&A there, then we'll try to get to we will try to get to all of your questions during this time. So Dr. Salgia, a little bit more about the work you do.
Thank you, Denise, and thank you for hosting us, and especially for the American Lung Association and everyone who works so hard. It's a pleasure to be with Dr. Amini. So I'm Ravi Salgia. I'm a Chicagoan, and I actually trained at Harvard Medical School, and I was at the Dana-Farber Cancer Institute and at the Harvard Medical School for 13 years. And then I moved back to Chicago at the University of Chicago as a tenured professor, and I was there for 13 years. And I've been here now for 8 years at the City of Hope. And my big expertise is in lung cancer, thoracic malignancies. And it is a pleasure working with Dr. Amini and all of our colleagues here at City of Hope and everyone at Southern California.
All right, Dr. Salgia, let's start with you. When a patient comes to you and they're newly diagnosed, they're scared, they have a lot of questions, maybe they weren't even smokers. What kind of hope, what do you tell them in the state of lung cancer treatment today?
Denise, we've come a long way. You know, I've been in practice for over 30 years now, taking care of lung cancer patients. What I used to do 30 years ago, what I used to do 5 years ago, no longer applies. Anyone who's been diagnosed with lung cancer, first and foremost, they should seek out an expert opinion. And they should also see what stage is the lung cancer, what type of lung cancer, what type of molecular abnormalities does the lung cancer have, and how best can we treat it. But you also have to take into account that it's a multidisciplinary effort. So you have to have medical oncology, surgical oncology, radiation oncology, pathology, pulmonary, social worker, nutrition. So all of those have to come into our equation to be able to help our patients with lung cancer.
Right, yes, and Dr. Amini, you're a radiation oncologist. Where does your field, your expertise fall into treatment? Does it depend which cancer, if you're the first doctor people see? I mean, I know they go to oncologists, but are you the number one treatment? Do people go to radiation first?
So great question. I think typically most of the patients start out seeing a medical oncologist, sometimes a surgeon. You know, radiation oncologists in general are not the first ones that patients see, but we're oftentimes involved in their care at some point of their treatment, sometimes early on, sometimes later in treatment. I think one of the things that we do here a lot at City of Hope is involve the radiation oncologist early. And even if that patient doesn't need radiation, at least to know what radiation is, to have an understanding of where we play a role, because we are involved with all stages of disease, different types of, whether it's, early stage, advanced, molecular status, all that we play a big role in. And I think, it's important for us to be involved early, and we typically are here at City of Hope.
And speaking of early, I mean, you want to be involved before the disease even starts. So let's talk about the state of screening.
So yeah, I think it's a great question. We have, our surgeons here have pioneered lung cancer screening, continue to work on that. It is still a disparity that we have in Southern California, and something that we're trying to address throughout the region. Lung cancer is a challenging disease, but caught early is curable. And so this is something that, while screening rates are improving, they are still drastically lacking throughout the Southern California region and across the country. And so I think getting out there, educating our primary care doctors about the importance of screening and trying to find a way to select patients and make them aware is really critical. I think, the month of November is a great month to spearhead this and promote it, but I think this is a year-round effort that needs to take place because we could really improve survival and save lives by screening.
Right, and I know smoking, if you're a former smoker, that's a reason to get screened. And Dr. Salgia, we talked about how smoking is a big cause of lung cancer, but it's not the only cause. So maybe let's take a step back and talk to people about the different causes of lung cancer and what lung cancer is.
So, lung cancer is a cancer that arises within the lung, but there are many different varieties of lung cancer. If you look at it under the microscope, you can have non-small cell lung cancer versus small cell lung cancer. Then non-small cell lung cancer can be divided into adenocarcinoma or squamous cell carcinoma or large cell. And you have to also take into account that lung cancer can have molecular alterations such as EGFR or ALK or ROS1 fusions, NTRK, MET. There's so many different variations of lung cancer that you have to really personalize and individualize the diagnosis of lung cancer, but then ultimately the therapy for lung cancer. Coming back to your question about smoking versus non-smoking, that's a very tough issue because I started my practice in Boston, then Chicago, and now here. Different populations are existing within the United States, and in Southern California, especially, and in California, we don't see as many smoking-related lung cancer. It's non-smoking related lung cancer. What is the cause of that is not very well understood, but we're clearly seeing younger patients, younger women especially, with lung cancer who've never smoked or never had secondhand smoking or didn't have other exposures like arsenic exposure or radon exposure as an example. So I do believe that one should be screened, exactly what Dr. Amini said. The American Cancer Society just came out with new guidelines compared to the NLST guidelines and the USPTF guidelines. And we had been involved in that early on. And we now know that you should be screened between the ages of 50 to 80 years old. And if you've had more than 20 packed years smoking history, and then there's no lifetime limitation, meaning in the past, it was like if you stopped smoking 15 years ago, then you might not need screening. But there are patients who've never smoked, never got exposed to smoking, who are developing lung cancer. We're trying to develop that algorithm for saying, who else should be screened? Should we screen patients of, let's say, certain origins who can develop lung cancer, or should we screen patients who have family members who had lung cancer? All of those are under research at this moment in time, but it's crucial if you have signs and symptoms, you should be checked out by your physician.
That is scary because a lot of people are staying away from smoking, but there are all these different causes, and we're still trying to understand that. So we want to educate people about treatment, and there are various forms that I've been lucky to report on all these years. The newest, of course, is targeted therapy, but lung cancer has been one of the first to employ immunotherapy, and Dr. Amini's specialty, radiation therapy. So depending on what caused your cancer or what type of cancer you have, is that how you determine which treatment to use? Either one of you.
Go ahead, Dr.
Dr. Salgia, start on the.
Okay, I'll start. So it's a very complex question. It sounds simple, but it's a complex question. So the type of therapy really depends on the type of lung cancer, the molecular alteration, what stage. Is it stage 1 or is it stage 4? Do we get involved radiation therapy, surgical therapy, chemotherapy or immunotherapy or targeted therapy? All of those are on the table for our patients. And that's why initially I said it's a personalized treatment decision-making. So we talk a lot about precision medicine, where we're looking at the genomics of the tumor or the proteomics of the tumor, meaning what genes are altered or what proteins are altered. If, let's say, you don't have any genes altered, but protein like PD-L1 for immune therapy is altered, then you can give immunotherapy. But then if you have a targetable or actionable mutation, can you get a targeted therapy? But it also depends if you're early stage. So in early stage, you have to consider perioperative therapy, or you have to think about neoadjuvant or adjuvant therapy, and then surgical resection. Then for later stages, can you consider other therapies, targeted therapies, radiation therapy? So all of those are becoming much more complex in our decision-making. And that's why I come back to my original comment that you need to seek out the experts. And this has really become a much more detailed types of therapies that not everyone can do.
Okay. And Dr. Amini, who is a candidate for radiation therapy?
So yeah, just along the lines of what we were just talking about, almost everyone to some degree, but again, it is personalized. I think, with the molecular testing, that has impacted how we treat as radiation oncologists. For example, lung cancer has a tendency to go to the brain. And, historically, we always radiated the brain. We have novel techniques to be very pinpoint now, but that doesn't necessarily mean in every patient we have to. There are certain drugs that patients have mutations for that go on that may not need radiation. So while I can say that radiation is very sophisticated now, very pinpoint, can be used in really all stages of disease, it is tailored to the patient based on where they're at in that treatment process. And again, I think why it's important, like Dr. Salgia was mentioning, to be seen by experts, have multidisciplinary care, have radiation oncology involved early, so at least that they can weigh in on that patient's journey on when there might be a role for radiation treatment.
And gentlemen, noticeably missing from that list is chemotherapy. Is that not something that you do for lung cancer?
Oh, no, chemotherapy is still the mainstay of therapy for lung cancer. And we have done so many clinical trials to bring chemotherapy to fruition, and it has a large role in lung cancer treatment. But again, it depends on the patient, their performance status, their age, their stage of the disease, what exactly is the type of tumor they have, can they get chemotherapy, will they be able to tolerate it? And you also have to take into account what kind of chemotherapy. In our decision-making process for chemotherapy, as an example, there's so many things that go into our minds to be able to say, should you do a platinum? Is it going to be cisplatin or carboplatin? Should you do pemetrexed, or should you do a taxane like a Taxol, paclitaxel, or docetaxel? And I can go on for a long time. Should you combine that with chemotherapy? Should you combine that with targeted therapy? All of those go into our decision-making, but chemotherapy is one of the mainstays of our therapies, and it does help our patients.
Wow, there are a million variables in there. So when a patient comes to you and you're telling them about the options based on their cancer, how do you simplify it for them? How do you make them understand what the course is going to be, how it's going to go from this point on?
Dr. Amini and I are working on this concept of what's called fast and frugal trees. I'll talk about the providers first. How do we help the providers make a decision? So, when a patient goes, let's say, to an emergency room with chest pain, you have to make a decision about chest pain. Is it related to the heart, or is it not related to the heart? If it's related to the heart, is there an ST changes that you need to act immediately? Do you need to go to the cardiac cath lab? Do you need to give some medications? Do you need to do something else? Those are fast decision-making processes that you have to make in the emergency room. Now, fast forward that to lung cancer treatment and lung cancer decision-making. If a patient comes to your clinic, what should you be thinking about to make decisions that are very appropriate? And so what is the age of the patient? What is the patient stage? What is the diagnosis of the patient in terms of the lung cancer? Then based on that, make a decision. So one example I'll give: the other day in the clinic, I saw a patient who's a 40-year-old woman who has an EGFR mutation, but they came to us for a consultation. They had an EGFR exon 19 deletion mutation with the 747 that she had previously received erlotinib, then developed the T790M mutation. Then we had to make a decision what to do. That's our first sentence, by the way, and in terms of evaluating that patient. So then you have to decide, what therapy do you want to give? You have to take into account, what is the tumor burden? Are there metastases to the brain or not? Are there pain issues you have to deal with? So all of that has to be taken into account in the clinic room. And so for patients, it becomes very important. Again, we come back to the concept, going to the expert, because not every person can make that decision. So go to the expert to help you make the decision.
Okay. I totally trust you. I totally trust you with everything, and I know your patients do too. Dr. Amini, there are various types of radiation therapies, if it should come to that. Maybe you can just discuss what the different radiation therapies are and the different technologies.
Yeah, so it's kind of pretty complex, but the general type of radiation treatment out there is photon therapy. That's PHOTON. Most of the country has that. Most of the world has that. And the other type of radiation is called protons, PROTON. Both are very accurate. Protons are thought to be heavier particles and maybe have less fall off radiation to your normal structures. Actively being studied in our field, we have evidence that it might be beneficial in a few sites for lung, other than when it goes to the brain and the fluid in the brain. We don't really have any good data for it, but it is a good option out there as well. But I think the real crux of radiation is what we call intensity modulated radiation therapy. And that's what brought our field from 20 years ago to now, where we bring tiny little beams of radiation to pinpoint and target tumors of various shapes and sizes anywhere throughout the body. And that can be done over a long course of 6 weeks, or what we tend to do a lot is a very short course. And that short course we've coined as SBRT, or stereotactic body radiation therapy. We can do that for tiny little spots in the brain, areas in the lung, or early stage lung cancer, for example, is treated with SBRT, has similar cure rates to surgery. And then even in the stage 4 area, we have, amazing therapies that Dr. Salgia and his colleagues have been giving our patients. And every now and then, some of our stage 4 patients, a few areas that start to grow, we don't want to take them off that therapy. We can come in and target those with radiation, or maybe consider surgery and keep them on that therapy for even longer. And so those are the general ways of radiation therapy. And, now, and we're one of the few institutions in the country to have it. We have a machine that's using tumors metabolism. So tumors, just like, our normal cells want to take up sugar and divide and try to survive. And we actually have a machine that targets that activity of the tumor. We'll actually be treating our first patient on it tomorrow. With lung cancer. So a lot of novel things coming down the line pretty rapidly. And I would say our field from 20 years ago to today is just completely different. And hopefully 20 years from now, people will say the same thing about what we're doing now.
That is just amazing. And it just, all this targeted therapy, it sounds like you're getting right to where the cancer is, right to the metabolism of the tumor, as well as, preserving all the healthy tissue. So that must mean less side effects, quicker treatment.
Exactly. And that's the whole goal of radiation. So if we can be more pinpoint, we can hit it with higher doses, less side effects, make sure that they can then continue on their systemic therapy. And that's really the goal of our field. And that's where we're heading. Radiation oncology is very technology based. So as technology improves, our field improves as well. And I think the next step is to catch up with our medical oncology colleagues and be more specific based on molecular testing on how, based on someone's molecular status, how we dose the tumor, where we treat, kind of how to predict early how tumors are acting. So there's a lot of research in that as well.
And Dr. Salgia, that's a segue to you, talking about personal medicine, targeted personalized medicine. Can you explain to people the difference between targeted therapies and immunotherapy?
Targeted therapy means there's a drug against a particular type of protein that's encoded by a gene. So as an example, a number of our patients have what's called an EGFR mutation. So EGFR represents epidermal growth factor receptor. And basically, it's an enzyme that drives the cell towards proliferation, meaning division and multiplying. It drives the cell for metastasis, like going from one organ into another organ. So there are drugs that are developed to inhibit this enzyme. And the initial ones were called gefitinib and erlotinib. Then fast forward, so many, 3 decades of research at least, and then you have newer drugs like osimertinib. And these drugs are called targeted therapies because they're targeting that particular enzyme or that particular protein to inhibit the cell from multiplying and then eventually kill the cell. Immunotherapy is different. Immunotherapy means that you're revving up your own immune system. Cancer is our own cells that refuse to die, basically, in a simpler definition. And so how do the cancer cells not die? How do they escape the vigilance of the immune system? So they can secrete substances or other things can happen that dampens the immune system. So if you give immune therapy, it really releases the brakes on that dampening. That sounds more like a double negative, but what that means is that immunotherapy revs up your immune system so you can fight the cancer from your own immune cells. So immunotherapy is given to a number of our patients as well, and you have to make those decisions which patients get it. We even give it in early stage, we give it in late stage. We're even seeing effectiveness, for example, in diffusely metastatic disease. And, you know, in my work for the past 30 years at least, we didn't used to talk about curing lung cancer in the metastatic setting. With immune therapy, we are seeing cures in the metastatic setting. Not everyone, and you have to be cautious in that statement. And even for targeted therapy, you're getting disease control for years and years and years. We have a number of patients who have, for example, metastases throughout their body who are living more than 5 years out, more than 7, 10 years. That's not true for everyone, so I want to caution us, but we are seeing that light at the end of the tunnel where we can do more research to be able to come up with cure, not only for stage 1 disease, but even for stage 4 disease. And we need to continue that fight against cancer this way.
That sounds exciting because it sounds like this could someday be a manageable disease, a chronic disease that you can manage with these different therapies. So you're saying like a combination of these throughout your treatment can just keep you alive?
Yeah, absolutely. Chronic disease is not so bad whatsoever, right? If we think about hypertension, diabetes, rheumatoid arthritis, they're all chronic diseases. They are controlled. The example I always give in the clinic is that hypertension, what does it mean to have control of the hypertension? That's by giving a medication. But you don't want no blood pressure. You want some blood pressure, right? So in the sense that if you can control the disease for cancer, such as lung cancer, you've achieved a lot. And that is one of our goals as well, not only to get to a cure, but while we're getting to a cure, can we convert the lung cancer into a chronic disease? And that comes with let's say surgery or radiation therapy or all the oncology therapeutics that we have, immunotherapy or targeted therapy or chemotherapies. So those are great goals as well.
Oh gosh, I mean, that's so touching. It gives so much hope to me, and I'm sure to everyone who's listening to this, if that's just around the corner. Are there any areas besides these 4 areas of treatment that are on the horizon?
Dr. Amini, I'll have you go first.
Yeah, I mean, I think Dr. Salgia summarized all that really well. I think in, radiation oncology, one of the areas that we are actively researching on is actually stage 4. And, when I tell patients and even colleagues about that, they, we used to never play a big role in stage 4 cancer. It was always radiation for palliation, something, patient had a disease in the bone and we would do radiation and help with their pain. Now, because of some of our amazing therapies from our medical oncology colleagues and how we are going into this chronic illness, we are trying to incorporate radiation to help control their disease, keep it chronic, and also deliver the radiation in a way so that we are maintaining quality of life. And so, myself and many other colleagues are really focusing on that stage 4 realm of doing aggressive radiation to kind of make it a chronic illness. And that was something, 5 years ago wasn't really talked about. It's literally the last 5 to 10 years where there's been a large amount of data coming out that says maybe we can be a little bit more aggressive in the stage 4 realm and keep people alive for many, many years. And I think that is going to be a blossoming area of research in our field. I think radiation oncology specific, there'll need to be continued amounts of work to improve our technologies. There's fancier ways now to deliver radiation within seconds. There's some early data that, radiation given, we call it flash radiation therapy, within a few seconds actually can have really amazing cancer kill rates. And so, keeping, research funding alive will only just better our outcomes. And so I think it's going to be a lifelong fight to just keep cancer research going and funding for our field.
So in terms of access to a lot of these treatments, are these in clinical trial stages? Are a lot of it FDA approved?
In a way, both for radiation oncology. So we have clinical trials, but a lot of these, a lot of patients have access to these radiation therapies now. We've been doing it here before even our clinical trial development. We were doing these targeted radiation approaches for our stage 4 patients. One of the things that a lot of hospitals are doing, including City of Hope, is expanding into the network. And so we have, as City of Hope Radiation Oncology, we have 20 some network sites throughout Southern California, out of state, so that what we can do here at the main center, we can bring out to the community as well. And so a lot of patients do have access to this, and a lot of patients end up coming here, for my opinion or my colleague's opinion, and then going closer to home at one of the City of Hope sites. And so a lot of patients already have access to this type of treatment.
Okay. Tell me about research. How is it going? Is there enough funding? Where are the barriers that or obstacles you are encountering when it comes to research?
It's very important to devote our energy into research, especially against lung cancer. Like I said, I've been in this field for 3 decades. We don't see enough funding for lung cancer research. We see more funding for other diseases per se, which is what it should be, but we should also prioritize our nation to be able to fund research against lung cancer. If exactly what Dr. Amini said, and what you said, is that it is the #1 cause of death in the United States for cancer, and yet it is not the #1 funded research. So we have to be able to say, let us start from grassroots. There are many programs, for example, American Lung Association hosts and other foundations host, other people really make it aware for lung cancer, as Lung Cancer Awareness Month is November, but not too many people know that. Others know, for example, one is the Breast Cancer Awareness Month, and we support that 100%, and all cancer awareness months, but it's Lung Cancer Awareness Month is near and dear to both of our hearts, and we want to be able to make sure we make a difference. So we should invest in research from the nation. We should invest in the research from the state. We should invest in the research locally and even on an individual basis. I can't emphasize that enough. We need to develop a blood test against detecting lung cancer. Those are coming to fruition. Those are in clinical trials to be able to say, why can't there be a blood test like there's a PSA for prostate cancer or CA-125 for ovarian cancer for some of those patients? Why don't we have one for lung cancer? Because up to 2/3 of lung cancer can go undetected until it becomes metastatic disease. And that's a tough issue. And we can't be doing scans after scans because that does have radiation associated with that. So you want to be careful as well. Then we have to invest in early stage disease. In our career, in the beginning, we would just do surgery for early stage and not do anything else. Then we started doing chemotherapy after resection of the early stage disease. Then now, most recently, we have FDA approval to do early therapy before surgery, then other therapies like immunotherapy or targeted therapy for early stage. We need to invest more in that research. We need to invest exactly what Dr. Amini said, stage 4 disease. Is radiation a great option? Are there potentials if we have, let's say, great responses to therapy, but one of the cancer gets left behind in the lung? So can you do surgical therapy in that case? Many of our patients develop metastases to the brain in stage 4 disease. How do we handle metastasis to the brain? Should radiation be given? Should immunotherapy, targeted therapy be given? Should we even think about surgical resection? All of those really need to have a path forward for us. And the only path forward that we can visualize is if we invest in the research. So we can come up with answers today to help patients not only today, but also tomorrow.
Interesting that it's that way. And do you think it's because of the stigma surrounding lung cancer? Oh, it's a smoker disease. Oh, maybe they did that to themselves. I mean, there's so many misconceptions.
We have to overcome that. It's several examples I use when I talk to others is, one is, smoking also causes heart disease. Yet we don't have that social stigma for heart disease and smoking, right? We take care of everyone and then there's no stigma whatsoever. When I was growing up, I was at the Johns Hopkins Hospital taking care of AIDS patients. In the beginning, there was a lot of social stigma associated with that. But then there became a lot of champions against AIDS, and we did away with that social stigma. It didn't matter how you got HIV positive disease. You just took care of it, and you're continuing to take care of it. And look at how we work together with our HIV positive patients and what great therapeutics have arisen. And there's really no social stigma associated with that nowadays compared to when I was taking care of our AIDS patients a long time ago. I think let's do away with the social stigma. It doesn't matter how you develop lung cancer. Let's cure lung cancer. Let's prevent lung cancer. That's the message we should be giving and we should be holding to our hearts.
Absolutely. We have a question from Holly in our audience. Does City of Hope have a screening bus?
I can answer that, if that's okay. So our colleague, our chief nursing officer, her name is Dr. Susan Brown, really started this momentum to have a screening bus. We're going to have a screening bus that will be manned by our nurse practitioner colleagues. And the first one will be in the Antelope Valley, because we worked with the local governance in the Antelope Valley region, and we are going to have that screening available to our patients. Our hope is that we're going to have a lot more buses over a course of time. So please look out for that. And it's not just screening for lung cancer, it's screening for prostate cancer, for breast cancer, for cervical cancer. So all of that will be available in the future. However, it's already available through your primary care physician, by the way, too. You don't necessarily need a bus. Please talk to your primary care physician, primary care provider, and say, I need screening for this, or can you consider me for screening of XYZ? Those are all important discussions to have with your provider.
Speaking of screening, okay, who is a candidate for it? I don't smoke, but when I was young, my grandfather smoked around me. But yet most of them in California, there's, like you said, there's a lot of people in California who don't smoke and yet have lung cancer. So would I be a candidate for screening?
It's a discussion with you and your primary care provider, just to make sure, because we have strict screening guidelines currently that we have to follow. And the most recent came out of the American Cancer Society that was just published recently. And the American Cancer Society guidelines state for lung cancer screening, the low-dose CT screening on an annual basis should be for 50 to 80-year-olds who have exposure to more than a 20-pack year smoking history. And it's a lifetime continuation of the low-dose CT. However, you're exactly right. If somebody has a family history of lung cancer, if somebody is a non-smoker but is a higher risk, insurance at this point, it has to be discussed with your primary care provider, but it is important to have that discussion with the primary care provider. And we do have exactly what Dr. Amini said. We have our surgical colleagues who are very involved with screening, and our pulmonary colleagues are very involved with screening. So certainly our colleagues definitely are happy to see you.
Okay. We have a question here from Guillermo. And this is one I want to know too, because I like air purifiers. He wants to know, what is the role of air purifiers in lung health, and what should we look for in a good air purifier?
That's a great question. To my knowledge, maybe Dr. Salgia knows better. I don't know of any good data one way or the other for an air purifier. There is data, though, that pollution can, contribute to lung cancer. So I think that that's important. But I personally don't have any information on what kind of good air purifier to get to kind of prevent or keep you healthy.
I think it's important to realize we live in Southern California, where there are a lot of fires, and you get exposed to all those toxins. And if you get exposed to all those toxins, and I live in Pasadena, and by the mountains, we had the big fires a few years ago, and they were actually throwing through helicopters all those flame retardants. They can't be good for you. So air purifiers are important to have, but which type, I agree completely, Dr. Amini, and how do you use it? Again, that's a discussion with the individual and their providers as well. I think the important is that our pulmonary colleagues always tell us breathing in fresh air is always good. But what does that mean if you have a lot of pollution? And I think we have to be cognizant of that as we go into the future.
Yes, I have one that's running all the time where I work because I feel better when it's on. But yeah, you have to check consumer reports, right, to see which is the best one. There's so many out there. A question from someone in our audience. Any thoughts on integrated oncology techniques like ozone, high vitamin C, and others? This is someone who really knows his stuff and wants to know more.
Yeah, I mean, I think it's an active area of research, probably something that our field should have, been a bigger part of a long time ago. City of Hope, we've gotten major grant funding, and maybe Dr. Salgia can talk more about that to involve integrative medicine. We have some lead physicians down at Lennar Cancer Center in Orange County to kind of incorporate that integrative medicine to our, contemporary treatments that we have here, like radiation, systemic therapy, surgery. There's both sides. So there's always a little bit of caution, specifically for a radiation oncologist. Radiation therapy creates free radicals. That's how it kills cancer, by damaging the DNA of cancer cells. So there are some older studies that when patients were on these antioxidants, vitamin C, for example, being one of them, ozone, with oxygen could potentially feed the cancer, impair the radiation treatment. And so right now, my advice to patients is, at least during the radiation, other than maybe a multivitamin, to avoid any type of high doses of antioxidants that you can inject in you. But how it maybe plays a role with us after the radiation treatment, I think, is an area that we need to actively pursue and research. So there, I'm sure, is a role, but we just have to be better about doing research and understanding that role.
I agree, Dr. Amini. We have a brilliant leader in our integrative medicine. His name is Dr. Richard Lee, and he's developing all these algorithms for considering when you should consider integrative medicine, how you should consider it. Are there alternative therapies that are available? Where do you put vitamin C into the equation, or other things that are injectable or you take by mouth into the equation? Where do you put in berries into the equation, like nutrition supplements and so forth? How does acupuncture come into the play? How does Tai Chi and Qigong come into play? So he's really developed a lot of that in our Lennar Cancer Center, exactly right, Dr. Amini, and also on Duarte now. And we want to implement that within the clinical network as well. We have a group of physicians who are doing that as well. But I must caution us because we don't know enough. Let's learn more. I'm of Indian origin, so I believe in Ayurvedic medicine because that's what we grew up with as a kid with my parents. But at the same time, I'm a traditional medical oncologist who believes in chemotherapy and targeted therapy and immunotherapy. But what roles do each one of us have, and how does integrative medicine come into play? Let's do much more research into it before we can answer that appropriately. A lot of our patients also ask not only about vitamin C and ozone, but what about THC and CBD? A number of patients take that. How does that come into play? We know, as an example, CBD can be a negative influence on immunotherapy. There have been a number of papers published, so you have to really talk to your oncologist to be able to say, is this okay? Is this not okay? And if the oncologist doesn't know, they can refer you to an integrative medical specialist who can work together with your radiation oncologist or medical oncologist. All of those have to be studied more, and we emphasize research, research, research. Let's get to those answers before pontificating what should be those answers.
There are so many people who do use CBD. So I'm glad you brought that up because I didn't realize it had an effect on immunotherapy. So important to know. We have a question from Rona, who is the chair of the 2024 Fight for Air Climb at the Coliseum. We'll be talking more about that. But she'd like to know, regarding patients on targeted therapy or chemo drugs with advanced stage, how close are we to getting them off indefinitely from these drugs?
try to answer that. Everyone wants to get off once you get on. No question. That's the first thing. And the second thing I always say is nobody wants to see me. And we want a day where nobody should see me or Dr. Amini. We want that day in the future, but let's make it in the present. I think it depends on the situation. If they're life-saving drugs and you believe strongly that they should continue, then they should continue as long as there's no severe toxicity and patients are responding. But as an example for immunotherapy, again, please talk to your doctor because this is just a general statement more than a specific statement. A lot of times what we do for immunotherapy in stage 4 disease is we stop after 35 cycles or 2 years of immunotherapy in metastatic disease. And patients do relatively well. But sometimes you have to continue based on how the disease is doing. Now, for targeted therapy, that's even a tougher question because we don't have enough information. What happens if you have metastatic disease and you're 5 years out? Can you be off of that therapy or not? These are life-saving therapies. So just like treating high blood pressure, where you're going to continue with your high blood pressure medication for life, I don't see an issue with that as long as there's no financial toxicity, as long as there's no toxicity, and you have to keep all of that into account. And again, it comes back to personalized medicine. Each individual has a different need, so we have to be aware of that and really cater to the individual, not to the statistic.
Financial toxicity, that's an interesting term. You mean, meaning if you can't afford the medications, if insurance won't cover it.
Targeted therapy, Denise, some of our targeted therapy, let's say if you're taking it lifelong, can be like $18,000 to $28,000 a month. So you could imagine if somebody doesn't have insurance, how are we going to pay for that? And you can also imagine somebody has insurance, but the copay is very high. So we're very thankful to the American Lung and other foundations where we really talk about these and try to come back to the payers, the insurance companies, to say these are life-saving medications and they should be paid for.
Evelyn has a question. Are there any nutritional strategies to fight cancer in conjunction with treatment?
I think that's a great question. And one of the things, I'm lucky in our clinic, we actually have a nutritionist, dietitian that helps with all of our patients. Generally, my approach is, we like patients to take in good calories. I always tell my patients to gain weight, not lose weight, which is kind of nice. And I encourage protein intake. So proteins, especially for radiation side effects, for recovery, really do help. So we try to encourage a well-balanced diet. I do talk to patients about sugar. That comes up a lot. I have patients that quit sugar altogether. They might have had a lifelong love for a cookie, and now all of a sudden I have patients that literally are miserable because they are avoiding sugar. And I tell patients, look, it's a well-balanced diet. So, high amounts of sugar, we want to avoid, but, a little bit of sugar is not going to feed the cancer. You really just want to stick to a good, well-balanced diet, keep a good weight on you. And I also, along those lines, encourage activity, exercising. Daily exercising is very important for patients and their outcomes.
I mean, all good information if you want to prevent cancer as well.
Exactly. Yeah. Cancer is a very unfortunate thing for, lung cancer, especially. And, a lot of times, our patients say, was there anything you could have done to avoid it? And there really isn't. But I just, tell all my patients, including my family, we can only do what we can do. And that's trying to live a well-balanced lifestyle, exercising, eating well, and then dealing, with our normal day-to-day stress and trying to keep things well-balanced as best as we can in Southern California.
Absolutely. We're all only human, and life is sure getting very fast-paced and stressful. So that's why it has to come back to balance. And Dr. Salgia, I feel your energy. You're very calming. It must be all that Ayurvedic background of yours. Giza has a question. She's a student lung cancer advocate. Is there a known threshold that can cause damage to your lungs when inhaling essential oils?
I think you have to be cautious no matter what you're inhaling except air. Oxygen is good for you. right? Air is good for you. But beyond that, everything can be a toxin, right, to your lungs. And we talked about pollution. Certainly, if you worked in like uranium mines and you get exposed to all that radon, that's not good for you either. Or if you lived in, let's say, New Hampshire or New England states, and radon is within your basement, as an example, and you have to screen for that. And it's in other states as well, and in the world as well. So inhalation of non-air particles can't be good for you. I think it can be enjoyable, but I wouldn't do it every day necessarily. I think you have to talk to your provider for sure. And there are elements that you inhale that can be very highly allergenic. And so if you have a lot of inflammation, that can't be good for you either. So I do think I'm not going against any industry that's providing all these for sure. I think in moderation is okay. But I do think it's an important discussion to have with your provider. It's important to know what your lung function is. It's important to know what your allergens are. It's important to know what other toxins are you getting exposed to. So is there a threshold? In my mind, the greatest threshold is continue to breathe great air. That's about it.
Best advice. So I mentioned Rona, who is the chair of the 2024 Fight for Air Climb that is happening at the Coliseum. And she wants to know, and we all want to know, if you're going to be there and how you're going to be involved.
I will be there, at least in volunteer status, but if I can do the climb, I'd be happy to take my newborn with me.
Just want to mention, we're planning ahead. This climb is going to be happening on February 25th. Dr. Salgia, I'm sure patients would love to see you there because they probably have a lot of questions for you. Are you going to be there?
Yes, for the American Lung Association and Maxine and Francis and all of our board of directors and our volunteers, I'm looking forward to seeing and our patients and families and everyone who wants to come. And I usually serve as the physician for the climb. So if you get a problem, you come and see me at the booth. And my wife does the climb, so I'll bring my wife along.
Yeah, it's an inspirational day. I mean, I've seen it. It's wonderful to have all the patients there, and they feel so great when they're able to climb the stairs, because usually it's been, months, years of struggle. So it's just a great day for everyone, especially, I'm sure, as providers, you would love your patients out there.
And I actually, as I understand it this year, coming up this year, Denise, is that you can even walk as well. So that's going to be a huge thing if you can't climb. I mean, I've seen in the past, we have our firefighter colleagues and other EMT colleagues who put on huge burden on their back and then climb those stairs like there's no tomorrow, and thank God for them, because that's phenomenal training. But we also want to have everyone partake in this activity, so you can even just walk as well.
You can walk, and apparently you can dance, because there's going to be dancing there, and there's going to be a festival. It's going to be a celebration. Firefighters, I guess, are going to be climbing with 100 pounds of gear. Good training for them. So yeah, it's going to be a wonderful day on February 25th, and we hope to see everyone who's watching this out there and supporting the American Cancer Society and all the great work they do and the information they provide with the state of lung cancer report that is out today. Any closing remarks, anything you would say to people who are watching this webinar, who are, they just want to know that everything's going to be okay? Want to start? I'll start with you, Dr. Amini.
I mean, I think I would reiterate what we said. I am a big believer in of what Dr. Salgia has brought up, that I do think lung cancer will be a chronic illness, and it already is for many of our patients. And I think, if any of you or your family members ever have to go through this, to seek expert advice and go to centers that treat a lot of lung cancer, and just believe in the belief that this will be a chronic illness. I do think that will happen in our lifetime.
Wonderful. Dr. Salgia?
It's such a pleasure working with colleagues such as Dr. Amini. I consider him my family, because all of our colleagues are so passionate and compassionate about taking care of patients and going through the journey together. We're as one big family together. We're truly inspired by our patients, and we want to make a difference for patients and their families as well. The biggest consideration for all of us is we really are thankful to American Lung Association for so many activities, and Denise, for you to spread the message as well. My ending statement is, why aren't we talking about cure for lung cancer from start to finish? Let's cure lung cancer stage 1 disease. Let's cure lung cancer stage 4 disease. That should be our motto, and that's what we should live by.
Absolutely. And again, this event is on February 25th. It is with the American Lung Association. I don't know if I misspoke earlier. The American Lung Association. We love the American Cancer Society as well. We all work together. But I just want to thank both of you for being part of this and spreading all this wonderful information and hope and inspiration, because it means a lot to everybody who's watching this. So thank you to both of you. And I just want to let everyone know, if you have a question, because we know we couldn't get to all of them today, if you are registered via email, these questions can be answered via email. So we will get an answer to you. So thank you to everyone who participated and watched and was part of this. We appreciate all the support that you give the American Lung Association, and all the attention that you give to this disease, and all the money and research and effort that you put into finding a cure and making this a manageable disease, and one where we can all unite together behind this cause. So thank you for watching. We appreciate your support, and we will see you at the next event.
Thank you.
Thank you. Bye.
Bye.